This presentation is going to discuss alterations of pulmonary function. There are certain signs and symptoms that will clue you into your patient's pulmonary disease. The first one is dyspnea, and this can occur transiently, or it becomes a chronic condition over time. And first, it can present during exercise, which is called dyspnea on exertion. You might see this abbreviated as DOE in a patient's chart. Whereas orthopnea is a type of dyspnea that happens during heart failure primarily. And this is when a patient is lying down in a recumbent or supine position, and this causes abdominal movement, the contents of the abdominal area, to exert pressure on the diaphragm, and it decreases the efficiency of the respiratory muscles. Different than just orthopnea is paroxysmal nocturnal dyspnea, which is when a patient with a pulmonary or cardiac disease wakes up in the middle of the night, they're gasping for air, and they have to sit up or stand up to help relieve the dyspnea. And this occurs because they've been laying down supine or recumbent for several hours, and so the fluid overload has had a chance to cause an issue with their pulmonary function. Now, dyspnea in and of itself is pretty subjective. It's the experience of discomfort when you're breathing, and it's the most common symptom of both respiratory and cardiac diseases. Sometimes it occurs with pain and trauma. Sometimes it causes anxiety or even psychogenic disorders. And the experience of dyspnea itself derives from interactions among multiple physiologic, psychologic, social, and environmental factors coming together to induce secondary physiologic and behavioral responses. According to the American Thoracic Society, they say that dyspnea involves 3 different constructs: the sensory, which would be the intensity of the dyspnea; affective, which is the distress, and the impact that it has on the patient's daily activities. It's compromised, or it can compromise a patient's ability to perform their activities of daily living, the things that maybe some of us take for granted because we have full function in both our respiratory and cardiac systems. Now, individuals with dyspnea may complain of feeling breathlessness, air hunger, shortness of breath, and may experience an increased work of breathing, chest tightness, and they are just preoccupied with breathing itself, where normally you and I, who do not have a respiratory dysfunction or disorder, aren't thinking about how we're breathing all the time. And the severity of the experience of dyspnea, it doesn't really directly correlate with the severity of the underlying disease because of the other factors that we talked about earlier, the intensity, the distress, and that it also has not only physiologic but psychologic conditions as well. Now, either there is a diffuse or focal disturbance of ventilation, gas exchange, or the ventilation-perfusion relationship, which could be mismatched, and this can cause dyspnea. Also, increased work of breathing or diseases that actually damage the lung tissue, like the parenchyma. There are neurophysiologic mechanisms for dyspnea as well, and this involves impaired sense of effort, where the perceived work of breathing is greater than the actual motor response that the patient is able to generate. There's also the stimulation of the variety of receptors that contribute to the sensation and the experience of dyspnea, and this includes the lower airway mechanoreceptors, remembering from our structure and function lecture, these are the stretch receptors, the irritant receptors, and the C fiber receptors, which are also known as the J receptors. We also have to consider the upper airway receptors and central peripheral chemoreceptors that interact with the respiratory center and the sensory and motor cortex. The more severe signs of dyspnea that you're looking for include nasal flaring, the use of accessory muscles upon respiration, retraction, which is a pulling back of the supracostal and the intercostal spaces. This predominantly occurs in children, but you may see it in adult patients as well. Now, in dyspnea that's caused by parenchymal disease like pneumonia, you will actually see retractions of tissue between the ribs, and you'll see them in the subcostal and the intercostal spaces. And they're observed more often than the supracostal retractions, which are retractions of tissues above the ribs. These symptoms and signs predominate in an upper airway obstruction. Now, dyspnea can be quantified by the use of ordinal rating scales or a visual analog scale, much like how we would ask our patients to rate their pain. Now let's talk about signs and symptoms of pulmonary disease. Cough is a common respiratory symptom, and it is a protective reflex that we all have to help clear our upper airways. And if we accidentally inhale particles or accumulate mucus, or if there's inflammation in our airway, maybe even a presence of a foreign body, something that should not be there, it's going to initiate the cough reflex by stimulating the irritant receptors in our airway. And remembering from our last presentation, we have different receptors in these airways that will trigger and cause us to expel or to cough the foreign particles, the mucus, or the foreign body. The cough reflex itself consists of inspiring air, then the glottis closes, as well as the vocal cords, and there will be contraction of the expiratory muscles. Then we have the reopening of the glottis, and it's going to cause a sudden forceful expiration, removing what was irritating our upper airway in the first place. And the effectiveness of the cough has to do with the depth of inspiration, the degree in which the airways were actually narrowed, and the increasing velocity of expiratory gas flow. We also have somatosensory nerves that innervate our chest wall, our diaphragm, and the muscles in our abdominal system. These all regulate our cough pattern and the sensitivity that we have. Cough occurs frequently in both healthy individuals and non-healthy individuals. With the healthy individual, we're trying to protect ourselves, but sometimes in an unhealthy individual, they have a greater risk for pneumonia because they don't have a cough reflex that enables this the presence or the ability to have this explosive expiration. Maybe the musculature of their respiratory system is not intact and they don't have the ability to cough. Now, this urge to cough sensation and the cough motor response can all be manipulated as well by distraction, by cognitive states such as anxiety, or if we just reflect on the voluntary component of cough itself. We also have central modulation of the cough reflex, and this is influenced by drugs like opiates and also other different serotonergic agents as well. We also have to think about cough in terms of, is it acute cough or is it a chronic cough? An acute cough usually lasts about 2 to 3 weeks from the onset of illness, and then it will resolve as there's either treatment or the underlying condition is able to come to resolution. However, sometimes it can last a little bit longer, be more persistent. Chronic cough usually happens and lasts, about 7 to 8 weeks or more. The textbook will also say that it is cough that persists 3 weeks or more. However, just like I said before, if you have something like acute bronchitis, that lingering cough may continue even past the 3 months, but I would still, 3 weeks, but I would still consider that part of the acute cough symptom. Now, what could cause an acute cough versus a chronic cough? Acute coughs are usually caused by upper respiratory tract infections, allergic rhinitis, maybe even having pneumonia, congestive heart failure, a pulmonary embolus, aspiration, and again, acute bronchitis. Somebody with a chronic cough, this can be from having a long-standing obstructive respiratory disease like COPD, someone that is smoking actively, someone that has postnasal drainage syndrome, or they have non-asthmatic eosinophilic bronchitis. Asthma, GERD, all of those conditions can also cause someone to endure chronic coughing. Now, in those individuals who smoke and have chronic bronchitis, this is the most common cause of a chronic cough. And although chronic bronchitis should be considered, lung cancer always has to be considered as well. Additionally, patients that are on an ACE inhibitor or an angiotensin converting enzyme inhibitor for their hypertension, they may develop a chronic cough too as an annoying side effect of taking an ACE inhibitor. And usually, you know this because if you switch their antihypertensive medication or stop the ACE inhibitor, the chronic cough resolves. Additionally, let's talk about abnormal sputum. If there's any change in the amount, the color, the consistency, or the smell or odor of the sputum, this may be an abnormal progression of disease. It can also tell us the effectiveness of therapy. If the sputum is thinning out, the color is resolving, there's less sputum, this also tells us that maybe the overall condition is getting better. We aren't going to look at the microscopic appearances, you and I, but we can send a sputum culture to the lab and they can actually look at and identify cellular debris or microorganisms that are in the sputum, and this can help us to determine the diagnosis or the choice of therapy by recognizing what bacteria is within the sputum. Hemoptysis is bloody secretions or bloody vomiting, and this is happening from the lower respiratory tract, and it's sometimes confused with hematoemesis. Hemoptysis is expectoration of the blood from the lower respiratory tract, where hematoemesis is more of the upper respiratory, from the GI tract, right? Because it's vomiting of blood. Now, blood that is expelled and considered hemoptysis is usually going to be bright red. And again, this is blood that hasn't been mixed in with your stomach content or your stomach acids. So we're going to see some bright red blood. And it can often be mixed with frothy sputum as well because it's still in the airway or the respiratory tract. Now, blood that is vomited, that is dark, has an acidic pH or mixed with food particles, this is hematoemesis, and it's coming from the GI tract. When someone has a hemoptysis, this usually allows us to know that maybe there's infection or inflammation or damage from bronchitis or bronchiectasis that's offending the bronchi of the patient, or maybe their lung parenchyma. This would be diseases like pneumonia, TB, or maybe a lung abscess. We would see hemoptysis as well. Other things that we would consider include lung cancer. Maybe there is some type of pulmonary infarction. These would also lead to hemoptysis. And the amount of bleeding, the duration of bleeding, this is also important. It does provide us clues about the source of blood. Ultimately, though, if you want to know exactly where this blood is coming from, you can have your provider order a bronchoscopy, or you can get some radiology reports, or images, and specifically a chest x-ray or a CT could also help you to understand where the blood is coming from and to confirm the site of bleeding. Now, if a CT or a bronchoscopy is not enough, you might have to look to an MRI. And then lastly here, we'll talk about abnormal breathing patterns. When someone is breathing normally, we use the term eupnea, E-U-P-N-E-A. And this is rhythmic, it's effortless, they're not thinking about it. And usually the ventilatory rate that we're looking for, 8 to 16 breaths per minute. Remember from our last presentation on structure and function, the respiratory rate, as we call it, is actually the ventilatory rate. Now, the tidal volume would range from 480 milliliters. Now, with short expiratory pauses, each breath, an individual takes an occasional deeper breath or a sigh. These sigh breaths help us to maintain normal lung function, and they usually happen 1 to 2 times during the normal tidal volume and about 10 to 12 times per hour. The rate, the depth, the regulatory, and the effort of breathing really are characteristics that we need to think about, because these are occurring in response to physiological and pathophysiological conditions. The patterns of breathing usually are automatic and they will adjust because we're trying to minimize the work of our respiratory muscles. So what could change this? Strenuous exercise or metabolic acidosis. Both of these things can actually induce acousmal type respiration or hyperpnea. And acousmal respirations are characterized by slightly increased ventilatory rate, but having very large tidal volumes and no expiratory pause. And you can see here on the slide, this middle one is an example of acousmal breathing. And you can see that it occurs in metabolic acidosis, and it may be also accompanied by ketones, uremia, sepsis, salicylates, methanol, aldehydes, all could cause or be accompanied by acousmal breathing, as well as lactic acid or someone in lactic acidosis. Now, labored breathing occurs whenever there is an increased work of breathing, or if there are obstructed airways, especially in patients that have chronic obstructive pulmonary disease or COPD. Now, if your large airways are obstructed, then you're going to have a slower ventilatory rate. Your patient is going to have to increase their effort to breathe, and there's going to be periods of prolonged inspiration or expiration. They may also have stridor, which are these very high-pitched sounds made during inspiration. Or they might have audible wheezes, which is a more whistling sound upon expiration. These are very typical of a COPD patient with large airway obstruction. However, in small airway obstruction, like in asthma, but we can also see this in COPD as well. In small airway obstruction, there may be rapid ventilatory rate, smaller tidal volumes, increased effort, prolonged expiration, and wheezing is very often present. When we have patients with restricted breathing, this is caused by things like pulmonary fibrosis that actually stiffen the lung tissue itself, the chest wall, and it decreases the compliance. What's your result? It's going to be smaller tidal volumes because you don't have the ability to move the lungs, and you're going to have rapid ventilatory rate or tachypnea, very fast breathing. There's some other abnormal breathings, the Cheyne-Stokes respiration. Now, if someone is in shock or has severe cerebral hypoxia, meaning that there's not enough oxygen to the brain, this can cause them to gasp for air, and they have this gasping respiration, and it's going to consist of very irregular, quick inspirations, and it's going to be accompanied with expiratory pauses. On top of that, anxiety can cause sighing respirations that consist of irregular breathing, characterized by very frequent, deep sighing inspirations. With Cheyne-Stokes breathing, these respirations are characterized by alternating patterns of very deep and shallow breathing. There may be apnea lasting 15 to 60 seconds, and then you'll have ventilations that increase in volume, and then at that time, the ventilation or the tidal volume will decrease again and go back to these periods of apnea or a period of non-breathing or respiration. So Cheyne-Stokes respirations are a result of a condition that will slow the blood flow to the brainstem, which then slows the impulses sending information to the respiratory centers of your brainstem. So whenever you see Cheyne-Stokes breathing patterns, you think of neurological impairment above the brainstem being the most frequent contributing factor to the breathing pattern. Now, hypoventilation, this terminology sometimes gets mixed up as well. Hypoventilation is not having enough or having inadequate alveolar ventilation in relationship to the metabolic demands that your body has. Hypoventilation occurs when the minute volume, remember minute volume is your tidal volume times your respiratory rate, which is your ventilation rate, when TV times RR is reduced. Now, it's caused by alterations in the mechanics of your pulmonary system, but it can also be caused by neurologic control of your breathing as well. In conditions where your alveolar ventilation is normal, your CO2 is going to be removed from the lungs at the same rate in which it's produced by cellular metabolism. And therefore, the arterial CO2 pressure is going to be above the normal level, or remain at the normal level, which again is 40 millimeters per mercury. But in patients that have hypoventilation, remember the CO2 is going to lag. The removal of that CO2 is lagging behind the amount of CO2 that's being produced. And therefore, your arterial CO2 pressure will increase and cause hypercapnia. Hypercapnia is high CO2 in the arterial system, greater than 44 millimeters per mercury. So there's not very much difference between a normal level, which is a 40, and an abnormal level of hypercapnia that's at 44 millimeters per mercury. And this is the result, it's resulting as there are increases in the hydrogen ion concentration in the blood, which makes it more acidic. CO2 is acidic. This is termed respiratory acidosis. And respiratory acidosis can actually affect the function of other tissues throughout the body and not just the respiratory system. Hypoventilation is often overlooked until there's severe consequences, because the breathing pattern itself and the ventilatory rate just kind of appears normal at first. And then there's changes in tidal volume, and then it's just kind of difficult to detect clinically. And this is why it's important that we actually will get an analysis of the blood gas. And this is again getting an ABG, arterial blood gas, and we're getting blood from an artery. And we're trying to measure the arterial pressure of CO2 and the levels in our arterial blood. But we can also check with capnography. And this is the measurement of CO2 concentrated in our expired air. And so with capnography, we often put a tool, we connect it to whatever breathing or ventilatory device our patient has, and every time they expire air, we can measure how much CO2 is being removed. And this would reveal the hypoventilation or hypercapnia that the patient has. Now, when someone has very pronounced hypoventilation, this can cause a patient to become very disoriented or cause them to be very quiet. Secondary hypoxemia can also occur. Remember, this is oxygen in the blood. And this is because there is going to be an accumulation of your alveolar CO2, which then displaces the oxygen that's in your blood. The opposite of hypoventilation is hyperventilation. And this is when alveolar ventilation exceeds the metabolic demands of our body. So now our lungs are removing CO2 too fast, at a higher rate than is being produced by cellular metabolism. And this is going to result in a decrease of PaCO2, which is also called hypocapnia, meaning that the arterial pressure of CO2 is going to be less than 36 millimeters per mercury. Remembering again that 40 millimeters of mercury is the normal range. Now with hypocapnia, this can result in respiratory alkalosis and can also interfere with our tissue function at other areas of our body. But just like hypoventilation, when we have hyperventilation, we need to have an arterial blood gas analysis, an ABG, or capnography to actually help us to quantify the degree of hypocapnia, or a decrease in the CO2. Hyperventilation commonly occurs when someone has severe anxiety, and it even can be seen with acute head injuries as well. Cyanosis, this is a term that we use to talk about the bluish discoloration of the skin, the mucous membranes as well, and it has to do with the decreased amount of hemoglobin. So there is desaturation, reduced hemoglobin in the blood, which is bluish. And generally, this is going to develop when you have 5 grams of hemoglobin that's being desaturated, regardless of the hemoglobin concentration itself. First, you might see peripheral cyanosis. This is telling us that there's slow blood circulation in the fingers and the toes. And this often happens when there is intense peripheral vasoconstriction. And you might see this in Raynaud's disease, or when someone's in a cold environment or very stressed out severely. You will have peripheral vasoconstriction. Now, with peripheral cyanosis, we can most often realize this first in the nail beds themselves. So we look at the nails. Now, central cyanosis, this is happening when there's a decreased arterial oxygenation or a low PaO2. And this is occurring from pulmonary diseases or could be a cardiac disease as well. Central cyanosis, this is best seen in the buccal mucosa inside your mouth and your cheeks. Can also be seen on your lips as well. So peripheral versus central cyanosis. Now, the lack of cyanosis itself doesn't necessarily tell us that our patient's oxygenation is normal. In adults, really you're not going to see signs of cyanosis until it's very severe. Until there's severe hypoxemia, you might not notice at all. And at that point, you may have missed other indications of respiratory failure, or your patient may already be in respiratory failure. Now, someone with severe anemia, remember, anemia has to do with hemoglobin as well, inadequate hemoglobin concentrations, and with carbon monoxide poisoning, this is a situation where hemoglobin will bind to the carbon monoxide instead of binding to the oxygen. These can also result in inadequate oxygenation to the tissues of your body, and you may not even see any signs of cyanosis. In individuals with polycythemia, this is condition where there's just abnormal red blood cells. There's an abnormal increase of these blood cells. But you may have cyanosis with tissue oxygenation when it is adequate as well. The significance of cyanosis is a clinical finding that still has to be interpreted in relationship to the underlying pathophysiology of other conditions. So when you see cyanosis, you want to check the PaO2 level through an ABG as well. Clubbing is something that we can also use to understand our patient's respiratory status. It's the bulbous enlargement of the end of our finger, or that distal segment. And the severity can be graded 1 through 5. You've probably discussed this in health assessment as well. And it has to do with the extent of the nail bed hypertrophy, the number of changes in the nails themselves. Usually clubbing is painless and it develops gradually over weeks. And commonly it's associated with diseases that disrupt our normal pulmonary circulation. And this is going to cause chronic hypoxemia. So these conditions are things like COPD, bronchiectasis, cystic fibrosis. We might see it with lung abscesses, congenital heart disease. It's rarely reversible with treatment of the underlying pulmonary condition. Now, although we don't really understand the pathogenesis of clubbing, there is a hypothesis that has to do with the megakaryocyte. And what it talks about is that the megakaryocytes and platelets are clumping together and trying to escape filtration in the pulmonary bed. Then they start to enter the systemic circulation, and these platelets release a growth factor in the nail bed, and this is what's causing the periosteal changes, or the change in the shape of the nail bed itself. Now, pain, pulmonary pain specifically, anything that's caused by a pulmonary disease usually is originating in either the pleura, the airways, or the chest wall themselves. Now, pleural pain, this is the most common type of pain that we'll hear about when someone has a pulmonary disease. And usually your patients will say that it's sharp or it feels like something's stabbing their thoracic area. Infection and inflammation of the parietal pleura, this is called pleuritis or pleurisy. This can also cause pain, and this is because of the stretch receptors during inspiration. Because of the inflammation that's in that area or the infection, every time they take a deep breath in, they feel pain. The pain, though, is usually localized to just portions of the chest wall and not generally over every area of your thoracic cage. Where there's a unique breath, you can actually hear maybe pleural friction rub. This is something in your respiratory health assessment lab you may have talked about. This pleural friction rub may also be accompanied with pleural pain, and it would be heard over the painful areas. When someone coughs, it actually makes pleural pain worse. When someone laughs, it can also make pleural pain worse as well. When you have an infection or inflammation in the trachea or the bronchi, this could be called tracheectasis, tracheobronchitis. This can also cause a central type of chest pain, and it's very pronounced after coughing. And this pain can make it very difficult for you to differentiate, is this a respiratory pain or is this a cardiac pain? I say make sure you've done everything to rule out the cardiac etiology as well as the respiratory etiology. High blood pressure in the pulmonary circulation, or it's called pulmonary hypertension. This can also cause pain as well, especially during exercise or exertion. And it also is something that can be mistaken for anginal pain or cardiac pain. Overall, pleural pain is most common with a pulmonary infarction or tissue death, and this is caused by pulmonary embolism. And you will have patients, if they've had a pulmonary embolism, they will complain of chest pain also. So those are the things that you're trying to rule out whenever you hear about pain that may be of respiratory etiology. But again, very important that you not only consider the respiratory etiology and even the musculoskeletal etiology like muscle pain or rib pain, but you have to be able to rule out the cardiac pain as well. We're going to move on now to conditions caused by pulmonary disease or injury. So we talked about this terminology just a little bit, but let's now talk about it under the umbrella of pulmonary disease. Hypercapnia, which is having too much CO2 in our arterial blood, is caused by hypoventilation. So it's the opposite. Low ventilation, high CO2, right? Because we're not allowing enough CO2 to be diffused out. Now, CO2 is easily diffused from the blood into the alveolar space. This is how we get that minute volume that we talked about, which is respiratory rate times tidal volume. And this is going to determine not only our alveolar ventilation, but also our PaCO2. Hypoventilation, again, is often overlooked because it looks like everything's normal, but we have to get a lab test, which by now you should know is an ABG. Now, there are many causes of hypercapnia, and we've talked about some already, but we're going to go through here and talk about it in list form. One is the depression of the respiratory center by drugs. When you take a drug, maybe for instance like morphine, it suppresses the respiratory drive, and if you're not breathing or having enough ventilation, then you're not blowing up enough CO2. So this could be a condition with hypercapnia. If there's a disease located in your brain, specifically at the medulla, and this could also be infection of the central nervous system or trauma, this could lead to hypercapnia. If there's abnormalities of the spinal conducting pathways or your spinal cord itself, this can also cause hypercapnia. Any disease that affects the neuromuscular junction of the respiratory muscles can cause hypercapnia. So those things would be like myasthenia gravis or muscular dystrophy. If there's abnormalities of the thoracic cage, or there's some type of injury to the chest or to the ribs, maybe there's a congenital deformity, this can also lead to hypercapnia. Obstruction of the large airways, think about tumors, and even sleep apnea. And then lastly, when there's an increased work of breathing or increased physiologic dead space, this can be seen in emphysema. These conditions can also lend to hypercapnia. Hypercapnia, remember, is associated to respiratory acidosis. Now, of the greatest concern is electrolyte abnormalities that occur in response to having a low pH, and this may cause dysrhythmias. So not only are we worried about too much CO2, but now we're worried about the electrolyte imbalance that tries to compensate for having a lower pH or acidosis. Now, patients that are starting to not be as responsive, or they are feeling more fatigued, or you're noticing somnolence, this could mean that they may be entering a coma, or that there's changes in the intracranial pressure that's associated with having too much CO2, too high levels of arterial carbon dioxide. This is important to recognize because having too much CO2 levels in your brain are traveling through that get to your brain, it can actually cause cerebral vasodilation. And this is when you're going to see these weird neurologic manifestations. Your patient's not acting the same, or they're not going to be as responsive. Now, the alveolar hypoventilation with increased alveolar carbon dioxide concentration really is limiting the amount of alveolar oxygen that's available for this diffusion of CO2 and O2. And this is going to lead to secondary hypoxemia. Hypoxemia is the reduced oxygenation of arterial blood, and it's caused by respiratory alterations. Think about when someone has hypoxia or ischemia, or if there's reduced oxygenation of the cells in your tissues altogether. This can be caused by alterations of other things as well and affect your other systems of your body. Cyanosis, hypoxemia, hypoxia, these all can also exist independently, but they are very interrelated as well. So think of hypoxemia. Hypoxemia can lead to hypoxia, because if you don't have enough oxygen in the hemoglobin, then you can't get oxygen to the tissues, leading to tissue hypoxia. Now, tissue hypoxia can result from other abnormalities as well, like just having low cardiac output. This can also cause this, but there is a direct correlation to hypoxemia and hypoxia. Hypoxemia results from problems with at least one or more of these major mechanisms of oxygen. Okay, so oxygen being delivered to the alveoli. Maybe there's a low oxygen content of the inspired air. And we talked about this in structure and function. They have a low FiO2. Maybe the ventilation of the alveoli is what's affecting it as well. Now, there's also the diffusion of oxygen from alveoli into the blood. If there's a balance between alveolar ventilation and perfusion mismatch, or a VQ mismatch, then this can cause a deficiency of diffusion of oxygen. Also, just having the diffusion of oxygen across the alveolar capillary membrane, if there's a deficit there, you're not going to get enough oxygen into the blood, as well as perfusion of the pulmonary capillaries as well. Now, this could all lead to acute respiratory failure if not corrected. So we're going to look at this for a second. We talked about ventilation and perfusion, or the VQ. And when you are thinking about this, you want to think about first the amount of oxygen in inspired air. It's being expressed as a percentage, the FiO2. When we say someone has an FiO2 of 21%, that is our baseline, that's our normal, because the fraction of air that's in oxygen, or the FiO2, at sea level is approximately 21%, or 0.21. Anything that will decrease your FiO2, like being at high altitudes, will also decrease your PaO2 as well. And this partial pressure of oxygen in the alveoli, this is what we're talking about when we're referring to PaO2. And it's dependent on two different things. But the second factor is important. The second factor is the amount of alveolar minute ventilation. How much tidal volume times the respiratory rate. And hypoventilation will result when there's an increase in your partial pressure of oxygen, and there's a when there's an increase in your partial pressure of CO2, but a decrease in your partial pressure of oxygen. This is going to cause hypoventilation. There's less oxygen available in the alveoli for diffusion into the blood when this happens. This type of hypoxemia can be completely corrected if we can improve the alveolar ventilation. How do we do this? If we can increase the rate and the depth of someone's breathing, we can correct alveolar ventilation or ventilation perfusion mismatch. Conditions that can cause hypoventilation that causes hypoxemia, unconsciousness, any type of neurologic lesion. It could be muscular. Maybe it's a bone disease that restricts your ability for your chest to expand. And COPD are examples of conditions where hypoventilation causes hypoxemia. Diffusion of oxygen from the alveoli into the blood is dependent on the two factors. Okay, so we talked about the second factor. Let's talk about now the first factor. The first is that there's a balance between the amount of air getting into the alveoli, and that is what is being depicted by the V in the VQ mismatch. Okay, so V is the balance between the amount of air that's actually getting into the alveoli, and then Q is the amount of blood perfusing to the capillaries around the alveoli. When there's an abnormal ventilation perfusion ratio, or what we call a VQ mismatch, this is the most common cause of hypoxemia. In a healthy lung, the alveolar capillary lungs will, the units will actually receive almost an equal amount of ventilation to perfusion. And this is at a ratio of about 0.8 to 0.9, because perfusion is just a little bit greater than ventilation in the lung bases. And also, some blood is normally just going to be shunted back into the bronchial circulation. VQ mismatch is referring to an abnormal distribution of ventilation and perfusion. Okay. When you have hypoxemia caused by inadequate ventilation of these well-perfused areas of the lung, you'll have low VQ. When you have this type of mismatch, this is called shunting. And this type of mismatch occurs in patients that have atelectasis, or if they have asthma that's caused by bronchoconstriction. Patients with pulmonary edema and pneumonia, they will also have low VQ, and therefore they will have a VQ mismatch. Hypoxemia can also be caused by poor perfusion of very well ventilated portions of the lung, and this is called a high VQ. This results in wasted ventilation. Now, the most common cause of wasted ventilation or high VQ, this is going to be a pulmonary embolus, because it's impairing how much blood can actually get to a lung area. The area where the alveoli are ventilated, but then they're not perfused, this is called the alveolar dead space. Okay, so they become ventilated, but they do not get perfused. Okay. So now we're going to move on to acute respiratory failure. And this can sometimes just be called respiratory failure, RF. And this is occurring when there is inadequate gas exchange. So hypoxemia of a partial pressure of oxygen below 50 millimeters per mercury, or if there's hypercapnia where the partial pressure of CO2 is over 50 millimeters of mercury, so too high. In addition, if there's a pH less than 7.25, this would all be the definition of respiratory failure. And it can be a result from a direct injury to the lungs, a direct injury to the airway, the chest wall, or it can be because of another disease or injury that involves other body systems and not just the respiratory system, like the brain, the spinal cord, the liver, or even the heart. And it occurs in individuals who may otherwise have been healthy or they had a normal respiratory system. But it can also happen to patients with underlying chronic pulmonary disease. Now, most of the pulmonary diseases can cause episodes of acute respiratory failure. So respiratory failure itself is not a disease, but can be caused by these underlying disease processes. If the respiratory failure is primarily hypercapnic, meaning that the other values are pretty normal, but they're just retaining a lot of CO2, they're very hypercapnic, then it's the result of inadequate alveolar ventilation. And this person has to receive ventilatory support because we need to get rid of that extra CO2. And so your patient may be on a bag valve mask. They might have a non-invasive way of getting positive pressure ventilation. They may even have to be intubated and put on a mechanical ventilator to release some of this CO2. If the respiratory failure is primarily hypoxic or hypoxemic, this is when you have very low levels of PaO2. Then this is because there's an inadequate exchange of oxygen between the alveoli and the capillaries. And then therefore, this person just needs supplemental oxygen therapy. However, most people with respiratory failure, it's a combination of both. They have both hypercapnia and hypoxemic respiratory failure, and they're going to need not only oxygen, but ventilation support as well. RF, or respiratory failure, has the potential to complicate other situations like surgery, especially if it involves the central nervous system, the thorax, the upper GI or abdominal system. Persons that smoke are more at risk, particularly if they have an underlying pre-existing lung disorder or disease. If you have limited cardiac reserve, you're a patient with chronic renal failure, have chronic hepatic disease or liver failure, or you have lung disease, infections, these all are going to increase the tendency for you to develop some type of post-operative respiratory failure. And the most common post-op pulmonary issue is atelectasis, pneumonia. And then also patients can undergo pulmonary edema and pulmonary emboli as well. The prevention of post-op respiratory failure is going to be talked about more in your medical surgical class, but it does include frequent turning and positioning your patient, telling them to deep breathe, using the incentive spirometer, all ways to help deter post-op respiratory failure. Incentive spirometer really does give the patient immediate feedback on how much tidal volume they have, and it encourages them to breathe deeper, which we're trying to have them do so that we can move the accumulation of secretions and prevent atelectasis from happening. Supplemental oxygen can also be given if you're seeing signs of hypoxemia, and antibiotics as well if you think that there is a high risk for pneumonia to treat that bacterial infection. If respiratory failure develops, you are going to work with your respiratory therapist and your provider to determine whether this patient needs mechanical ventilation, high frequency ventilation, or they might even need extracorporeal membrane oxygenation. And how do we do this? At baseline, we need to first think about obtaining an arterial blood gas or an ABG. Now we're going to move on and discuss disorders that affect the chest wall and the pleura. Restriction of the chest wall can compromise our respiratory system as well. And if the chest wall is deformed, if it's traumatized, immobilized for some reason, or even if it's surrounded by heavy amounts of adipose tissue or fat, our work of breathing is going to naturally increase. But this is also going to cause ventilation to be compromised because of a decrease in the tidal volume. And the degree of impairment of our ventilation, or in terms of our ventilatory impairment, really is going to depend on the severity of the abnormality of the chest wall itself. For patients that are obese, they are often dyspneic, or they're going to have exertion when they are even laying down in a recumbent position. Individuals that have severe kyphoscoliosis, which you can see, which is a curvature of the spine here on this diagram, they are going to have dyspnea on exertion that can actually progress to a respiratory failure. There is a bending and a rotation of that spinal column, which distorts the thoracic cage area. Now, obesity and kyphoscoliosis, these are risk factors for respiratory failure, risk factors for infection, but they don't necessarily cause the respiratory failure in and of itself. Okay, but primarily these are going to cause a higher risk for these individuals to be going through things like infection. They may require surgery that increases their risk for respiratory failure as well, which we've talked about in previous slides. And they're going to be at higher risk for being admitted to the hospital. So all these together can increase the risk for respiratory failure. There are other musculoskeletal abnormalities as well that can impair ventilation, and this is ankylosing spondylitis. And you can see here in the second group of pictures what that means. And you can have inflammation of the joints and fusion of the bones that causes a lot of back pain. But because of this, there could be a deformity of the thoracic cage. Also, pectus excavatum, which is deformity where you see a depression in the sternum. You can see this at the last picture there. This also is a deformity of the chest wall and could cause ventilatory issues and impairments. In all, respiratory muscle function, this impairment of this function can be caused by neuromuscular disease. It can also be caused by the trauma itself, getting into a car accident, something putting increased pressure on the thoracic cavity or posteriorly on the back. These could cause impairments to the pulmonary function. Also, muscle weakness. If you have muscle weakness in this thoracic area, it can cause hypoventilation, hypercapnia, and you might have the inability to remove secretions, which at some point will also lead to hypoxemia as well. Now, flail chest is a type of chest wall disorder, and flail chest is the instability of a portion of the chest wall, and it could occur with a fracture of consecutive ribs. It could happen in one place, or it could be a fracture over the sternum, or several consecutive ribs in other places. With flail chest, you have the instability of a certain portion of the chest wall, which then leads to paradoxical movement of the chest wall when you are breathing. During the negative interthoracic pressure that occurs with inspiration, the unstable portion of the chest will move inward, and then during expiration, it's going to move outward. This is impairing the movement of gas that needs to happen naturally in and out of your lungs. Usually, flail chest is associated with underlying lung contusion, like some type of a trauma. Other clinical manifestations that you're going to see are chest pain, dyspnea, obviously unequal chest expansion, and hypoventilation. The only way to really treat flail chest is to stabilize that chest wall by internal fixation, and you need to control the the ventilation by actually helping with mechanical ventilation until that chest wall can be stabilized. A pneumothorax is a pleural abnormality of the lung, and primary or spontaneous pneumothorax occurs in healthy adults, and it occurs unexpectedly. Usually we see it more in men than in women, and between the ages of 20 and 40 years old. These are the conditions in which spontaneous rupture of blebs, or these blister formations that are on the visceral pleura, will occur, creating primary spontaneous pneumothorax. Smoking is also a risk factor as well. Now, these blebs can rupture in your sleep, they can rupture with rest, they can actually rupture with exercise as well. They're located along the apexes of the lungs, and we're not really sure exactly how these formations start off. But we know that 80% of patients have found to have emphysema-like changes in their lungs, even if they have no history of smoking at all and there's no underlying genetic disorder. Okay, so those are the patients that have bleb formations. Now, 10% of these affected patients have a significant family history of having a primary pneumothorax that is linked to an autosomal dominant mutation in a gene called the folliculin gene. And this causes cell-to-cell adhesion, cell growth, which then leads to cystic lung disease and kidney tumors as well. What happens when these blebs rupture? They actually will damage the visceral pleura and create a conduit for air to then travel away from the lower airways into the pleural space. This is called a bronchopleural fistula. We also have secondary pneumothorax. And a secondary pneumothorax, this is caused by some type of chest trauma. Usually we're going to have accompanied rib fracture. Maybe it was caused by a stab or a bullet wound, or a surgical procedure that kind of went amiss and tore the pleura. At this time, the rupture of a bleb or a bulla can also occur, especially in patients with COPD. We can also cause secondary pneumothorax with mechanical ventilation. So the same device that we're using, the same machine that we're using to help with ventilation, can actually cause more issues, especially if the patient has positive end expiratory pressure, which we call PEEP, P-E-E-P, in addition to their mechanical ventilation. Now, primary and secondary pneumothorax can present as either an open pneumo or a tension pneumo. In an open pneumo, this is sometimes called a communicating pneumothorax. In a tension pneumo, the site of the pleural rupture itself is a single one-way valve that only permits air into during inspiration, but it doesn't let any air escape during expiration. So I'll repeat that again in the next upcoming slides. Okay. So a pneumothorax in general is the presence of air or gas in the pleural space, and this is caused by a rupture in the visceral pleura. The visceral pleura is the area that surrounds the lung. It can also happen in the parietal pleura and the chest wall. A open pneumothorax, sometimes called a communicating pneumothorax, will occur again when air pressure in that pleural space equals the barometric pressure, because air that's drawn into the pleural space during inspiration is forced back out during expiration. So it's communicating that area. The damaged chest wall and the parietal pleura, or it can happen through the lungs and the damaged visceral pleura. These are all places where you can have air moving through this pleural space during inspiration and then force back out during expiration. As opposed to a tension pneumothorax. Now, with a tension pneumothorax, the site of the pleural rupture is only a one-way valve. It permits air in when we're inspiring air, but it's not going to allow any of this air to escape because it's closed during expiration. So then, as more and more air enters the pleural space, there's nowhere for it to go. So this air pressure is going to increase in the pneumothorax. It's going to exceed the barometric pressure. With air pressure in the pleural space, it's going to then push against the lung that's already kind of recoiled, and this compression is going to cause compression atelectasis, and it's going to move against the mediastinum, displacing the heart. It's going to also displace the great vessels. It may displace your trachea, which is a health assessment finding that helps us to understand that maybe there is a tension pneumothorax. If we don't fix the pneumothorax or allow this air to escape with a chest tube or needle aspiration of the air, the pathophysiological effects of this tension pneumo can become life-threatening. You'll discuss the interventions for pneumothorax more in your medical surgical nursing class. Here is just another picture of pneumothorax to help you understand that as air enters that pleural space, it's going to disrupt that negative pressure that's there to cause the lungs to fill the space up normally. And so the difference between an open and a closed pneumothorax, and you can see here the tension pneumothorax, moving everything, shifting it towards the mediastinum and relocating or displacing the heart and the great vessels. Other pleural abnormalities is pleural effusion, and this is when there's fluid in the pleural space. So with the pneumothorax, there was air. Now there is fluid, and the source of the fluid is usually because a blood vessel or a lymphatic vessel underneath this pleural area. But sometimes it can actually be caused by an abscess or other lesions that drained into this pleural space. And effusions, when they enter this pleural space from an intact blood vessel, they can actually be very watery, and we call this transudative. Or it could be exudative, which there's a lot of protein in this source. We could see the fluid accumulating at a much faster rate, and it's not allowing the lymphatic system to eliminate the fluid fast enough. There's other types of pleural effusion as well, like if there's pus instead of the watery exudate or transudate. If there's pus, we call it empyema. If there's blood, we call this pleural effusion a hemothorax. And if there's chyle, which is lymphatic fluid, we call this a chylothorax. And you can see here summarized on this table the mechanism of the pleural effusion, what is actually being accumulated, and what disorders are linked back to the type of effusion. So for instance, with empyema, which again is pus, you might have infection bringing in microorganisms, leukocytes, and other cellular debris. It's going to be dumped into that pleural space, but then it's being made at a rate too fast for the lymphatic vessels to actually drain it out, and it's being blocked. This happens when there is an infection such as pneumonia, or if there's a lung abscess or some type of infected wound of the pleura. Okay, so that's how you would use this chart to review the mechanisms of pleural effusion. So we went over pus, but go back and look at hemothorax, the chylothorax, exudative, and transudative, which is the watery fluid or hydrothorax, as it's called. Now we're going to talk about restrictive lung diseases. With restrictive lung disorder, or RLD, we are going to have a decrease in the compliance of our lung tissue, which means that we are going to need more effort for inspiratory expansion. This is all going to increase the work of breathing. And our patients with lung restriction, they're also going to have dyspnea. They're also going to have an increased respiratory rate or ventilatory rate. Their tidal volume will decrease as well. When you get a pulmonary function test, you might see that there's actually decreased functional tidal volume. You'll also see that restrictive lung disease can cause a VQ mismatch, and it will affect the alveolo-capillary membrane itself. If it's affecting the alveolo-capillary membrane, we're going to have this reduced diffusion from the alveoli to the blood. All in all, this is going to lead to hypoxemia. Then we'll have activation of macrophages and PMNs, which are polymorphonucleocytes, and lymphocytes as well. They are going to release numerous inflammatory and immune cytokines. This happens in some of the most common restrictive lung diseases, which in adults are aspiration, atelectasis, bronchiectasis, bronchiolitis. We see it in pulmonary fibrosis. We see it in diseases of inhalation. We might see it in pulmonary edema and in situations of ARDS, which is acute respiratory distress syndrome. These diseases are characterized by the macrophages, the PMNs, the lymphocytes, cytokines, just like you see here. Let's go back and revisit this term in pink, the VQ mismatch. There's a slide previous that talked more about the VQ mismatch, but we're just going to revisit for a second. This is the ventilation perfusion. And this mismatch happens when part of your lung is receiving oxygen without blood flow, or it's receiving blood flow without oxygen. And it happens when we have obstructive airway diseases. Okay, so say you're choking and there's no air coming down the major airways, you might have a VQ mismatch. Or if you have an obstructive blood vessel itself, such as a clot in the lung, this would also cause a VQ mismatch. It's whenever part of your lung is receiving oxygen without blood flow, or it's receiving blood flow without oxygen. The term VQ, you're probably wondering, well, why Q? Well, Q actually stands for the blood flow. And this term VQ represents the ratio between the ventilation, which is the V, the perfusion of blood flow, which is the Q in the lungs. So this VQ mismatch is referring to this imbalance of how much air reaches the alveoli for gas exchange. This is ventilation. And then the amount of blood that reaches the alveoli for oxygenation. This is called perfusion. Another restrictive lung disease is aspiration. This is a passage of any fluid or solid particles that travels to the lung. And it can occur if someone has the inability to swallow, or they have an impaired cough reflex, even if they've had a decreased level of consciousness, or any type of central nervous system abnormalities. And some of the predisposing factors are altered level of consciousness that can happen if someone is under the influence of illegal substances, alcohol, sedation, anesthesia. Maybe they have an underlying seizure disorder or neuromuscular disorder as well. Because this could cause dysphagia or the difficulty with swallowing. It can cause esophageal disorders and trouble within the esophagus itself. Maybe there are strictures that have formed, causing them to not be able to move things down the esophagus properly. Even think about a situation where you might have to put an NG tube or a nasogastric tube into a patient, then this could block the airway, and it can also cause aspiration. In terms of anatomy, what is important to remember is that the right lung, particularly the right lower lobe itself, it's more susceptible to aspiration than the left because the branching angle of that right mainstem bronchus is straighter than the branching angle of the left mainstem bronchus, which is more diagonal. So it makes it easier to aspirate into that right lower lobe. And if we aspirate food particles or any large particles, we will have serious consequences because these particles can actually obstruct the bronchus, which would cause inflammation. It can cause a collapse of the airway that's distal to the obstruction itself. Now, if we can't find what actually was aspirated or we aren't able to identify it, we can get a bronchoscopy to try to remove it. But there's also going to be chronic local inflammation that develops in that area. Sometimes it could be irritation from the bronchoscopy, but maybe there's infection in that area. And this infection can cause bronchial inflammation, and this can also cause a situation where aspiration is a little bit more relevant. And you might even see the collapse of the airway itself. We might see this also in bronchiectasis, which bronchiectasis is the permanent dilation of the bronchus. Now, sometimes our patients will actually aspirate oral or pharyngeal secretions, and this can lead to aspiration pneumonia, which is primarily bacteria. This can happen when we have intubated patients and they're put on mechanical ventilation. You can also aspirate acidic gastric fluid. Now, with a pH less than 2.5, this can actually, which is very acidic, can cause pneumonitis. And this can irritate the esophagus and cause further damage to the esophagus, along with the respiratory system itself. Bronchial damage is going to be affecting our overall ability to breathe, but also this aspiration has just made it worse because it's causing inflammation. We have that loss of ciliary function, which would normally move up the disease or the offender or the aspect that shouldn't be going down to our respiratory system. We don't have that function anymore because of the bronchial damage. We can also have bronchial spasm, which would increase our risk for aspiration as well. Additionally, in the alveoli, acidic fluid damages the alveoli capillary membrane. This allows our plasma and blood cells to move from capillary into the alveoli, but with all this acidic fluid, it can result in a hemorrhagic pneumonitis as well. Surfactant production is disrupted when we have a patient who has aspirated. And when our surfactant is disrupted, then we're going to have collapse because remember the surfactant open up those alveoli and increase the surface area. When we have surfactant disruption, it can lead to further edema. It can make the lung itself non-compliant and stiff in that area. Aspiration is commonly associated and connected with infection. And this infection with aspiration can further lead to hypoventilation, and also it can lead to hypertension as well. So there will be systemic complications. What are the clinical manifestations? You're going to see patients have a sudden onset of choking, intractable cough, meaning they just can't stop. Could be with or without vomiting. You might see fever because of maybe aspiration pneumonia. There's a bacterial component or just infection in general. Chronic cough, persistent wheezing. Sometimes this can last over months and even years when from the initial aspiration event. There are different types of atelectasis. Atelectasis in general is the collapse of lung tissue. We have compression, absorption, and then we have the surfactant impairment atelectasis. And then we'll talk about post-op atelectasis at the end. With compression atelectasis, this is caused by some type of external pressure compressing or exerting on the lung tissue. And this occurs when there's a tumor or there's fluid in the or air in that pleural space. It can be at the base of the lung caused by abdominal distension as well, because not only do we have the abdominal distension outward, but it can be pressed upward towards our thoracic area, pressing on part of our lung. This can cause our alveoli to collapse. Absorption atelectasis. This happens when there is a gradual absorption of air from an obstructed or a hypoventilated alveoli. It can also happen when someone has inhaled concentrated oxygen or anesthetic agents as well. We get absorption atelectasis, very gradual. Surfactant impairment can also cause atelectasis. So, the demographic that is most at risk for surfactant impairment are our premature infants, because they may have been born before 32 weeks, and this is where our surfactant is then now being produced and ready to go and help pop out those alveoli. Surfactant impairment is going to result from either decreased production or inactivation of surfactant. We need surfactant to reduce the surface tension, open up the surface area in the alveoli, and it prevents the lungs from collapsing when we expire air. We need a little bit just to keep it popped open at all times. We don't want to expire everything out. Now, we also have atelectasis that occurs after surgery, this post-op atelectasis, and we've talked about it a little bit previously. For those patients that are been given general anesthetic during surgery, they're going to be the most at risk. And post-op patients that have pain, they tend to breathe a little bit more shallow. They may be reluctant to change positions, and they may produce more viscous secretions, and these secretions are going to pull in the portions of the lungs that are dependent, which means that if you're sitting up, the dependent areas of the lungs are the bases. But if you're laying to the side, the dependent side is whatever side the patient is laying on. Okay, so particularly those who have surgical procedures involving the thorax or the upper abdomen, those are the patients that are going to be most at risk for this post-operative atelectasis. And atelectasis increases pulmonary shunt. It will decrease your lung compliance, and overall can lead to perioperative hypoxemia, things we want to stay away from. What might you notice in your patient? We might see the same things that are similar to a patient with pulmonary infection. We'll see the dyspnea, the cough, the fever. We'll see an increase in their white blood cells or leukocytosis. How do we prevent and treat this? We'll talk more about this in your med-surg class, but deep breathing, turning, using the incentive spirometer, all ways to help with this. Also, you can give surfactant. Artificial surfactant can be given to our premature patients, but we can also give surfactant to our adult patients as well. Bronchiectasis is another type of restrictive lung disease. Sometimes it's confused with bronchiolitis, which is primarily a pediatric concern. You're going to see that on the next slide. Well, bronchiectasis, this is a persistent abnormal dilation of the bronchi. And usually it has to do with genetics, or it can be caused by a defect in our defense. And it occurs in conjunction with other conditions like chronic bronchial inflammation. Maybe we have obstruction of the airway because there's a mucus plug. Sometimes this happens with intubated patients that aren't able to bring up their own secretions, and they haven't been have not been able to remove their mucus plugs. Maybe the respiratory therapist hasn't been able to remove it, or the nurse. It can also be caused by atelectasis, aspiration, infection, cystic fibrosis, tuberculosis, and congenital weakness of the bronchial wall itself. Even patients that are immunocompromised are at risk for bronchiectasis. Okay, again, the abnormal dilation of the bronchi, and it's persistent. It's also associated with systemic disorders like rheumatological diseases, rheumatoid arthritis, inflammatory bowel disease, and immunocompromised patients like those that have AIDS are also at risk for bronchiectasis. Sometimes people get bronchiectasis and we don't know why they got it in the first place. A patient with bronchiectasis usually has a recurrent infection or chronic inflammation in the bronchi, and this is going to lead to an obstruction of the elastic and muscular components of the walls of the bronchial area, and the bronchial lumen now becomes obstructed. We might even have traction from adjacent fibrosis, causing permanent dilation. This bronchial dilation can be cylindrical, or it can be symmetrically dilated as well. And with the symmetrically dilated airways, we usually see this in patients with pneumonia, and at that time, it is reversible. Saccular bronchitis, this is when the bronchi become so large and balloon-like, they actually look like a varicose vein or a big bulbous area. So varicose bronchiectasis as well. What's important is just to know the overall term of bronchiectasis. Now, constriction and dilation will deform the bronchi. You'll be left with this bulbous appearance, and sometimes the connections between the bronchial and pulmonary blood vessels occur, which these connections are called anastomosis. This will increase the blood flow through the bronchial circulation, and it could cause hemoptysis. Remember, this is the bloody discharge that can occur with patients. We do see hemoptysis with bronchiectasis. Additionally, you'll see airway damage leading to bronchospasms, and with the bronchospasms, bacteria have a chance to colonize in this area, which would then promote infection and further lung disease. We'll have the inability for ciliary function, so the mechanism that we have to move out debris and infectious substances isn't going to work. All of this then produces this copious and purulent type of mucus, and there's nowhere for it to go. We will also see ventilation perfusion mismatch. which will result in hypoxemia. Sometimes you will also see changes in your PaCO2 level, and the minute ventilation becomes compromised. The primary symptoms of bronchiectasis are chronic cough, lasting months to even years. And the diseases that are commonly associated with bronchiectasis are the lower respiratory tract infections. Most of the times when we have patients with bronchiectasis, they have lots and lots of mucus. And it's not only just the amount, but also it's foul smelling at times. And you can actually try to measure this for your patient and send it to the lab so that we can figure out what the bacteria is. If they're not receiving an antibiotic, they probably need one. That sputum with the foul smelling odor really gives us a clue that maybe this patient needs antibiotics. With bronchiectasis, we might even see clubbing of the fingers because with bronchiectasis, we have chronic hypoxemia, very common. This leads to clubbing. The hemoptysis is from the mucosal inflammation and necrosis that's happening. Sometimes it can be just a little bit, and sometimes this bleeding can be massive. Additionally, more common things are like pleuritic chest pain, fatigue, and dyspnea. Bronchiolitis is an inflammatory obstruction of the smaller airways, or the bronchioles. More commonly seen in children, but we also see it in adults. It usually occurs with chronic bronchitis, and in otherwise healthy individuals, it's going to be associated with having some type of underlying viral infection or inhalation of a toxic gas. With the viral infections, something like RSV or respiratory syncytial virus would be one of the things that could cause an older adult to have bronchiolitis, and RSV is very common for children as well. And so being a pediatric patient under the age of 1 and premature infant as well, they have a very high risk of RSV, respiratory syncytial virus. We also have atelectasis, or destruction of the alveoli caused by emphysema that may develop distal to the inflammatory lesion itself. But usually bronchiolitis is diffuse, and we will see a connection with a decrease in ventilation perfusion ratio. So there will be a mismatch. VQ mismatch results in hypoxemia. That's an important underlying concept throughout this presentation. The decrease in minute ventilation will also result with carbon dioxide retention, and this is going to occur as the restriction of the lungs becomes worse. Things that you might notice in your patient: the clinical manifestations, rapid ventilatory rate, use of accessory muscles, retraction, low-grade fever. They might have a dry, non-productive cough, and you might notice a hyperinflated chest as well. If bronchiolitis occurs by inhalation injury, you might also see pulmonary edema. Most of the time, respiratory distress with severe hypoxia is going to happen within 24 to 72 hours. If you got a chest x-ray, you'd be able to see infiltrates, and you would notice the decrease in the ventilation perfusion ratio, again, resulting in hypoxemia. How do we diagnose bronchiolitis? We're going to get spirometry, bronchoscopy with the biopsy, and once we are able to diagnose, then we can give the appropriate antibiotics. We can also give corticosteroids for inflammation, provide immunosuppressive agents, and chest physical therapy actually works as well, providing humidified air, coughing, deep breathing, and postural changes. The last thing is something called bronchiolitis obliterans organizing pneumonia, and it's a complication of bronchiolitis obliterans. This is what happens when the alveoli and the bronchioles become so filled with connective tissue that we will have pneumonia. Bronchiolitis obliterans syndrome is an inflammatory fibrotic process that occurs with complications of lung transplantation. The diagnosis of this is also made by spirometry and bronchoscopy with a biopsy. Most of the time, you're using corticosteroids and other immune modulators to help with this bronchiolitis obliterans organizing type pneumonia. Pulmonary fibrosis is another restrictive lung disease that occurs when there's an excessive amount of fibrous tissue or connective tissue within the lung. And this pulmonary fibrosis can cause formation of scars over the lung fields, and usually this is happening after some type of active pulmonary disease like acute respiratory distress syndrome or tuberculosis. Also, pulmonary fibrosis is associated with other autoimmune diseases like rheumatoid arthritis. There might be someone that has also had inhalation of some type of harmful substances, maybe in their occupation, coal, dust, asbestos. Now, this chronic inflammation can lead to fibrosis with alveolar epithelialization and myofibroblast proliferation. We are going to see decrease in lung compliance. These fibrotic scar tissues will make the lung become stiff, and it's going to be harder for ventilation to occur. You also are going to have a decrease in the diffusing capacity of the alveolar membrane, and this overall leads to a state of hypoxemia. When you have diffuse pulmonary fibrosis, there is a poor prognosis. And when there's no specific cause for the fibrosis, like it's not because of harmful substance inhalation, or autoimmune disease, or active pulmonary disease, then we call this idiopathic pulmonary fibrosis. With idiopathic pulmonary fibrosis, the most common interstitial lung disease itself, you are going to see this in men more than you are in women, and usually over the age of 60. You usually have a 2 to 5 year survival rate after the initial diagnosis. And what you're going to see is chronic inflammation, and the recent research has actually shown that it could be a result of multiple injuries at different lung sites over time, with alveolar wound healing that didn't go over so well. And now it's just a response of complex interactions of not only genetic things, epigenetic things, environmental insults, and metabolic factors all coming together. But overall, we're just not sure, and this is why it's called idiopathic pulmonary fibrosis. Inhalation disorders is in and of itself its own type of restrictive lung disease. When you inhale gaseous irritants, it can cause significant injury to your lung and cause respiratory dysfunction. And most of the time, these types of toxic gases that we're referring to are things like ammonia, hydrogen chloride, sulfur dioxide, chlorine, nitrogen dioxide are among some. And you can also get inhalation injuries that burn, and these are carbon monoxide, cyanide, and ammonia. We can get these from household items or cleaning agents or industrial combustants. Heat and smoke particles also can cause this inhalation disorder. So what happens when we inhale these toxic particles? They are damaging the airway epithelium. They can damage the cilia and the alveoli. Also, it can increase our production of mucus. It promotes inflammation, and it can further develop mucosal and pulmonary edema with airway obstruction. Also, the surfactant that we need to keep the alveoli patent, they can actually be inactivated. as well as antioxidants and protective buffers that we have within our respiratory system. There's also cellular effects that we need to think about as well. And this can happen with toxic gases, but it can also happen with polluted air in addition. So just go back and think about what are those cellular changes that can happen because of the environment. When we have acute toxic inhalation, frequently it can be complicated by the development of bronchoconstriction in addition. Airway obstruction with fibrous mucus. We can have a microcirculatory coagulopathy, and we can have impaired gas exchange, all related to this acute toxic inhalation syndrome. And the symptoms that you're going to notice first, your patients are going to complain of burning of the eyes, burning of their nose, burning of their throat. It's going to cause coughing, tightness of the chest, shortness of breath, or dyspnea. Hypoxemia is also going to be common in this as well. We have to think about secondary injuries also because of resuscitation of patients that have inhalation disorders, because of the use of mechanical ventilation, or there could be a secondary infection that has occurred. What would we do to treat these type of patients? Supplemental oxygen using ventilation in high frequency. We might use protective lung ventilation whenever possible. Inhaled anticoagulants because of the microcirculatory coagulopathy that's occurring. We might have to use bronchodilators because of the bronchoconstriction. And we're also supporting the cardiovascular system because it's so in tune with the respiratory system. Therefore, inhaled beta agonists might relieve this bronchoconstriction. And most people will respond pretty quickly to this type of therapy. And consider prolonged exposure to high concentrations of supplemental oxygen at the normal atmospheric pressure can also result in relatively high risk for rare iatrogenic conditions known as oxygen toxicity. So in these cases, we need oxygen, but if you use oxygen at such high concentrations, it can also lead to oxygen toxicity as well. And that basic mechanism causing oxygen toxicity is the severe inflammatory response that's mediated by oxygen free radicals. This is going to cause cellular necrosis, apoptosis, and damage overall to the alveoli capillary membranes. It's going to decrease our surfactant production, so it's not helping to pop open the alveoli. And we can also see interstitial and alveolar edema. This will decrease our lung compliance. This term, pneumoconiosis. Pneumoconiosis is a change in the lung because of inhalation of the inorganic dust particles. And most commonly, we are seeing this as a workplace type injury. It's because of our environmental surroundings and what we are breathing in. This is an environmental acquired lung disease. And so the history of exposure is really important, and understanding each patient, what they've been going through, where they work, how long they've worked in these situations. This is all going to help us to determine the underlying diagnosis. And pneumoconiosis occurs after years and years of exposure to whatever that particle was, the offending dust or the particles in the air, like maybe asbestos. And then it leads to progressive fibrosis of the lung tissue, and then increased risk for lung cancer. The dusts from asbestos, coal, and silica, these are the most common causes of pneumoconiosis. Other things like talcum powder, fiberglass, mica, clays, slate, cement, metals, These are all going to increase your risk of pneumoconiosis as well. Why are breathing these things a problem? Well, these materials in the lungs will release the pro-inflammatory cytokines, and this is going to cause chronic inflammation with scarring of the alveolar capillary membrane, resulting in primary fibrosis and overall progressive pulmonary deterioration. What type of signs and symptoms might you see? The clinical manifestations have to do with cough, sputum production, dyspnea, all things that are getting worse over time, decreased lung volumes, and hypoxemia. In most of the cases, this patient with pneumoconiosis is going to be diagnosed when you get a chest x-ray or a CT, or if you're just getting a very detailed occupational work history, you could probably support the diagnosis of pneumoconiosis. And the treatment is just treating the symptoms. It's symptomatic, it's palliative, there's no resolution for this disease, and it's really focusing on preventing further exposure to these dust particles, working in a better environment, and managing the associated hypoxemia or the bronchospasm that can happen. Silicosis is a type of pneumoconiosis that has to do with silica inhalation, so silicon dioxide. So that's just a term that's very specific to that type of dust particle. Then we have coal worker pneumoconiosis. Obviously, these are conditions that are affecting coal miners or those that have inhaled a lot of coal mine dust over time. And we also have, again, the asbestos. I do want to talk about quickly hypersensitivity pneumonitis, which is also called allergic alveolitis. This is an allergic inflammatory disease caused by repeated inhalation of organic particles or fumes. So the first ones were inorganic. Now we're talking about organic particles. And so these antigens can actually cause a disorder. This is why it's a hypersensitivity type of reaction. And bacteria, fungi, yeast also can cause a hypersensitivity pneumonitis. Microbacteria, contaminated mists from standing water, showers, and hot tubs. Actual proteins, animal proteins, can cause pneumonitis as well, like bird droppings, feathers, and then chemicals like paints, resins, and glues could also contribute to hypersensitivity pneumonitis. It is a type 4 hypersensitivity response, and it can be acute, subacute, or chronic, and most of the times the symptoms are flu-like. You'll have a fever, a cough, shortness of breath, or dyspnea. Your patient might even complain of chills for a few hours, but most of the time it's going to resolve without any treatment 1 to 3 days from the initial onset of the symptoms. However, if the patient continues to be exposed to these allergens or these particles, then they can actually develop pulmonary fibrosis, which we know can lead to more restrictive type lung disease issues. The diagnosis is made by getting a history of the allergen exposure. We can also perform serum testing for IgG antibodies to see what the triggers may be. We might do a chest x-ray, CT, bronchoscopy, and in rare cases, you may even need a lung biopsy. But again, if it's acute, usually it's going to resolve 1 to 3 days as long as you don't have this repeat exposure. Pulmonary edema is another restrictive lung disease that has to do with excess in water. So think edema and water. And the normal lung really has very little fluid. We want to keep it dry, and it's kept dry by our lymphatic system, lymphatic drainage, and the balance among our capillary hydrostatic pressure, our capillary onconic pressure and capillary permeability itself. Additionally, we have surfactant that lines the alveoli, which repels water. It keeps the alveoli open, but it also keeps fluid from entering the alveoli. So it is a water repellent. Predisposing factors that are common for pulmonary edema are patients that have left-sided heart disease, and this causes an increase of pulmonary venous pressure, injury to the pulmonary capillary endothelium, and like we saw with ARDS or respiratory distress syndrome, we also have inhalation of toxic gases, lymphatic obstruction, all contribute to pulmonary edema. The pathogenesis of itself, you can see here in this illustration, but there are other causes also, like rapid pulmonary re-expansion after some type of airway obstruction. Even exposure to high altitudes can cause pulmonary edema. But these are the three most common. Again, you see the left ventricular dysfunction of left-sided cardiac failure, injury to the capillary endothelium, and any type of blockage in a lymphatic vessel that would block the ability to remove this excess fluid from the interstitial space. So all of these things will lead to pulmonary edema. Now think about what happens with the alveolar capillary membrane in the presence of pulmonary edema. It's going to be impaired, especially if we aren't able to remove the excess fluid because there's a blockage of lymphatic vessels as well. We will see in the alveolar membrane, it's going to be thickened, and the surface area is going to be available for diffusion. That normal surface area amount, it's actually going to be decreased as well. The abnormal thickness that happens when we have pulmonary edema because of the tissue swelling, but we also have fibrosis, or the formation of this fibrous lesions that occur. Over time, they will increase what we need, the amount of time that's required for diffusion across the alveolar capillary membrane. So these are the diseases that will cause a dead space. And we talked about that earlier in a previous slide. It will also cause a decrease in FiO2 and create a shunt. What is the most common cause of pulmonary edema? It's actually going to be the left-sided heart failure. When that left ventricle fails, which you can see in the blue on this diagram, the filling pressure on the left side of the heart will increase, and then it causes an increase at the same time, an increase in pulmonary capillary hydrostatic pressure. This will then lead to the pulmonary edema. Let's now look at pulmonary edema in question form. What are the following characteristic features of the pathophysiology of pulmonary edema? Select all that apply. Pulmonary edema occurs when fluid accumulates within the alveoli, which are those small air sacs in the lungs, and this accumulation is going to disrupt the normal gas exchange and compromise respiratory function. Increased hydrostatic pressure in the pulmonary capillaries will be a common symptom or associated cause of pulmonary edema, and conditions that elevate your pulmonary capillary pressure, such as left-sided heart failure or fluid overload, it's going to cause fluid leaking into the alveoli. With increased permeability of the alveoli capillary membrane. Now, in certain conditions, like acute respiratory distress, which is ARDS, or pneumonia, the alveolar capillary membrane becomes more permeable. This increased permeability will then allow the fluid and proteins to move from the capillaries into the alveoli, which now is causing more fluid to accumulate, contributing to pulmonary edema. The lymphatic system also plays a critical role in draining excess fluid. And so when there's impaired lymphatic drainage from the lungs, you're going to accumulate more fluid, increasing the development of pulmonary edema. If this lymphatic drainage becomes impaired due to lymphatic obstruction or overload, the clearance of this fluid from the interstitium is going to be compromised, and therefore the alveoli are going to be compromised as well. When you have elevated blood pressure in your systemic circulation, like hypertension, it can contribute to the development of pulmonary edema as well. This increased systemic pressure is transmitted to the pulmonary capillaries, which results in an increase in hydrostatic pressure and fluid leaking into the alveoli. Okay, so both increase hydrostatic pressure in the pulmonary capillaries. You can see the connection with elevated blood pressure in the systemic circulation, which then also causes an increase in hydrostatic pressure and fluid leakage. All of these are correct. They are all part of pulmonary edema. The last of the restrictive lung diseases that we're going to talk about are the acute lung injury and acute respiratory distress syndromes. Now, ARDS is a fulminant form of respiratory failure. And how we characterize it is two things. There's going to be acute onset of bilateral infiltrates when you look at a chest x-ray, and we can't explain it by cardiac failure or fluid overload. The second thing is that we're going to see a low ratio of partial pressure of arterial oxygen to the fraction of inhaled oxygen, or the FiO2. Important mediators that are involved are macrophages, neutrophils, the complement system, and endotoxins. So this is just an overview. Now, all the disorders causing ARDS cause acute immune cell-mediated injuries to the alveoli capillary membrane, which then will produce massive amounts of inflammation, increased capillary permeability, alveolar flooding, right? And what we're getting is protein-rich fluid overwhelming these ion channels and lymphatic removal of fluid. The most common predisposing factor of ARDS is genetic. Sepsis, and if a patient has undergone multiple types of trauma, and especially if they've needed multiple blood transfusions. Now, there are cases like pneumonia, burns, aspiration, bypass surgery, specifically cardiac bypass surgery, pancreatitis, someone that has overdosed on drugs, inhaled smoke or noxious gases, oxygen toxicity, radiation therapy, if they have DIC, which is disseminated intravascular coagulation. It's a process where you have a lot of clotting followed by a lot of bleeding, and alcohol abuse and smoking. These are all risk factors for ARDS. So very, very many predispositions to having ARDS. Let's go back and talk about these mediators for a second and how important they are in the development of ARDS. The role of the neutrophil is central to the development. The activated neutrophil will then release inflammatory mediators. Among them, you're going to see proteolytic enzymes, oxygen-free radicals. We're going to see metabolites like prostaglandins, leukotrienes, and also platelet activating factor. And once these mediators are released, they are going to extensively damage the alveoli capillary membrane, increasing the capillary membrane permeability. Remember, the increase in capillary permeability, their capillary membrane permeability, is not good in this case. This increased capillary permeability is actually the hallmark of ARDS, meaning this is how we know ARDS is occurring. This is a key symptom because it's allowing fluid, protein, blood, all to leak from the capillary bed to the pulmonary interstitium and into the alveoli. So what are we going to get? With ARDS, we're also going to get pulmonary edema. We're also going to get hemorrhage, and it's going to really reduce your compliance of your lung severely, impairing alveolar ventilation. And when you have pulmonary edema in ARDS, it's not the result of sodium and water concentrations, capillary hydrostatic pressure, or onconic pressure. Okay, it has to do with this cascade of the mediators that are happening, starting with the neutrophils. Lung inflammation and injury will occur as well to the alveolar epithelium and the vascular endothelium. Surfactant also becomes inactivated, so we lose some of that surface tension of the alveolar, and the production by the type 2 alveolar cells is impaired. Now, as alveoli and respiratory bronchioles continue to fill with fluid and continue to collapse, our acute respiratory syndrome continues to get worse. Acute lung injury and acute respiratory distress syndrome represent a spectrum of acute lung inflammation and diffuse alveolo-capillary injury. Okay? But ARDS is going to be the most severe form, and this is why it's so important to understand ARDS specifically. And it does affect more than 190,000 people here in the US every year. And we do have advances in therapy to help with ARDS, particularly its ventilation therapy. And this is going to decrease the death rate by about 46%, depending on other comorbidities and illnesses as well. ARDS can occur directly from aspiration of acidic gastric contents, inhalation of toxic gases, and even pneumonia. We can also have it indirectly, like from the circulating pro-inflammatory mediators in response to some other systemic disorder like sepsis, trauma, or multiple transfusions. We also know that ARDS causes an acute immune cell mediated injury to the alveolar capillary membrane, which produces massive inflammation, increased capillary permeability, and alveolar flooding. This leads to pulmonary edema. So we've kind of circled back to pulmonary edema again. And you can see here a continuation of ARDS. I put this here so that you can see its connection to severe pulmonary edema, how it starts from acute lung injury like pneumonia or maybe sepsis, smoke inhalation, aspiration. But because of the cascade, starting from the inflammatory cytokines to the inflammatory cells like the neutrophils, macrophages, and platelets, we start to go through this cascade of complement activation. This is going to damage the alveolar cells and the endothelial cells. It's going to disrupt the alveolar capillary membrane. So therefore, there's going to be exudation of fluid, protein, and red blood cells that move into this interstitium. This is going to lead to pulmonary edema and hemorrhage. And we're going to see severe impairment of alveolar ventilation. This is called the exudative phase. Okay. Now, in the proliferative phase, this is when the type 2 pneumocytes or fibroblasts and myofibroblasts are proliferating and they are forming hyaline membranes. It moves then to the fibrotic phase, which is the progressive fibrosis and tissue remodeling that occurs. And at this time, you're going to have destruction of the alveoli and the bronchioles. All of this is going to cause acute respiratory failure, and you're going to see this by marked hypoxemia, hypercapnia, and acidosis. Now that is leading all the way through to this exudative, proliferative, and fibrotic phase. But let me deviate you just for a second here and go back to that fourth box on the top. Once neutrophil aggregation happens and the mediators are released, we're also going to see platelet activation. And when this happens, there's microthrombi that are forming in pulmonary circulation. We are also going to see vasoconstriction, decreasing flow to lung areas, causing pulmonary hypertension. And this is where that pulmonary hypertension is linked to pulmonary edema. Pulmonary hypertension plus atelectasis and decreased lung compliance lead to VQ mismatch. All of these things eventually are going to circle back to acute respiratory failure. It's very important that you study this connection very closely and understand how acute lung injury leads to acute respiratory failure, the connection of pulmonary hypertension, pulmonary edema, VQ mismatch, and the activation of inflammatory mediators. What does that do in this cascade of events? Be able to look at this and think about, what is the story here in each of the phases. Okay, so the first phase we'll talk about, again, following the diagram on the previous slide, is the exudative phase. This is also the inflammatory phase. It occurs within 72 hours of lung injury, and it is the result of inflammatory cytokines like the interleukins, and it will activate macrophages that will release more pro-inflammatory cytokines and more interleukins. We'll also see tumor necrosis factor alpha, surfactant protein D, mitochondrial DNA. So it's releasing all of these things. While this is happening, neutrophils are being activated, releasing proteolytic enzymes, and they will release reactive oxygen species as well, like free radicals, nitric oxide. We're also going to see other metabolites like prostaglandin, platelet activating factor. These things will damage the alveolar capillary membrane, increase the capillary permeability. You're going to have fluid, protein, and cells exuded. This is where we get the term exudative phase. They're going to be exuded into the interstitium and into the alveoli. When this happens, you're going to have a VQ mismatch, ventilation perfusion mismatch. Now, platelets and the complement activation will result in this hypercoagulable state with very small microthrombus formation in the intravascular spaces. And then you're going to have more damage to the lung capillary endothelium. When this happens, more release of platelets, neutrophils, and macrophages are going to further cause vasoconstriction and microthrombus formation. At this time, this is where the pulmonary hypertension is going to come in because of the microthrombus formation. And we're going to see pulmonary hypertension secondary to the vasoconstriction that is happening with the platelet and complement activation in this hypercoagulable state. We're also going to see in this phase surfactant becoming inactivated, and its production by the type 2 alveolar cells is going to be impaired. So as alveoli and respiratory bronchi continue to fill and fill with fluid, they're going to collapse. We're going to have intraalveolar hemorrhaging and hemorrhagic exudate. this is going to become cellular granulation tissue. And this is what we're talking about. It turns into hyaline membranes, which progressively causes hypoxemia. Your lungs are going to become less compliant. You're going to need increased work of breathing, and the ventilation of the alveoli will decrease. Because of this, you're not able to release the excess CO2, so hypercapnia is going to develop as well. In the proliferative phase, this only occurs within 1 to 3 weeks after the initial injury, and you're going to have a resolution of the pulmonary edema and proliferation now of fibroblasts and myofibroblasts and type 2 pneumocytes with surfactant recovery. So things are starting to get a little bit better. The type 1 pneumocyte differentiation with epithelial cell regeneration will occur at this time. Sometimes the phase will overlap with the fibrotic phase. The fibrotic phase happens within 2 to 3 weeks after initial injury. We're going to see remodeling and fibrosis occurring. And because of the fibrosis, it will obliterate the alveoli. It'll interfere with the respiratory bronchioles, interstitium, and it overall leads to a decrease in functional residual capacity. And this VQ mismatch that we had will continue. We're going to see this VQ mismatch with severe right to left shunting and then respiratory failure. When we have fibrosis of the pulmonary capillaries, we're going to have pulmonary hypertension as well. And so those same chemical mediators that were responsible for the damage at the alveolar capillary complexes will also cause inflammation in ARDS. It will also cause endothelial damage, capillary permeability that's happening throughout the body, but this capillary permeability will result in systemic inflammatory response syndrome, or SIRS, SIRS, systemic inflammatory response syndrome. This leads to multiple organ dysfunction syndrome, or MODS. With MODS, we are at very high risk for death. And so not only are we now experiencing respiratory type systems, now it's becoming more systemic at this point. And it's not just the respiratory distress that might kill a person in this situation, but it's also the multiple organ dysfunction syndrome that's associated with ARDS. Okay, so one more time. The clinical manifestations that you might see are dyspnea and hypoxia, even when you try to provide some type of oxygen supplementation. Hyperventilation and respiratory alkalosis. We're blowing off too much CO2 in this case. We might see then now leading to decreased tissue perfusion. With decreased tissue perfusion, now we're switching it up, and now we have metabolic acidosis and organ dysfunction. Our work of breathing increases, our tidal volume decreases, and we have hypoventilation. This hypoventilation will result in hypercapnia, where we have an increase of CO2, giving us now respiratory acidosis and worsening hypoxemia. Overall, this will decrease our cardiac output. This decrease in cardiac output leads to hypotension, which eventually leads to death. Let's quickly test our knowledge regarding acute respiratory distress syndrome. Which of the following statement is true? The answer here is B, the connection with pulmonary edema and ARDS. Acute respiratory distress syndrome, characterized by the damage of the alveolar capillary membrane, will cause severe pulmonary edema, and the most common cause of ARDS is either sepsis or multiple types of trauma. Macrophages
neutrophils, complements, and endotoxins are indeed important mediators in ARDS. The answer here is B.